of people. As a result, the suffering may be much less. They are thinking that, okay, it's nothing, it's just like a flu-like factor and it's going to go away. They're not thinking about the consequences it's going to have in long term. And these are the people who are coming now with long-term consequences of post-COVID or post-COVID phenomena. So don't take, what I always say is don't take COVID lightly. I'm not ready to have it. I'm not ready to have COVID. I don't want to have it. I would rather be stupid than be sorry. I would rather be blamed as the person who doesn't go out or stay in his home, who doesn't socialize. I'm ready to be that person. I'm ready to be that dumb person who stays at home. But I am not ready to suffer from this disease as far as I have seen. And I want everybody to be very careful because we really don't know where it goes and how it ends. We really don't know how it's going to affect our future. We really don't know how much cardiac effect it's going on and how far it's going to affect us. We really don't know if these patients who have suffered from COVID is going to have a heart attack pretty soon than others, or a stroke much more earlier than the others. So my suggestion is the only way out is to stay safe. We have the treatment. The death rate is very, very low in Bangladesh. Alhamdulillah, it's the blessing of Allah. But we really don't know what the post-COVID phenomena holds for us. So the treatment is there. We are managing the cases. We have been able to cut down the deaths. But we don't know what we are going to do with post-COVID. So till then, until a vaccine is available, I would suggest that everybody remain safe and stay in their homes. Try to avoid social contact as much as possible. Okay, another year, the vaccine would be there. I'm very optimistic. But till then, try to be safe as much as possible. And thank you very much. Thank you.
Thank you. Such an excellent explanation of rather you have completed every aspect of.
I think ma'am is having a few troubles with internet connection. Anyways, thank you so much, Dr. K. Mayas, for the valuable words. I have had relatives and friends myself who have been suffering from symptoms but have not got tested, despite myself begging them to do so. And this has been the case with so many people because they're trying to normalize the situation. But that's not the case, and that should not be the case for at least the next 6 or 7 months, in my opinion. So thank you so much for emphasizing on that again.
I have, Abrar, if I wanted to ask Dr. Ayaz, if you could kindly elaborate a little bit on cytokine storm. Everyone's scared, especially laymen. Yes. And what are we doing to
So basically, if we look at the COVID disease, we can divide it into the whole period. We can divide it into 3 parts. Say, for instance, the first 6 days, we can call it the Viremia phase, where the virus replicates. Now, after the viremic phase, what happens is during this period and onwards, the virus triggers the immune system in our body. This immune system causes an enormous amount of immunologically active agents to come out, or rather, to the layman's, if there are any in this audience, this is like when we launch an attack in any country, the country prepares itself and replies back to that attack by throwing arms and ammunition towards the enemies. That's what our body does as well. So when the virus goes in and it starts replicating, our body prepares itself to attack the virus, to launch an immune attack. This immune attack is directed towards the virus to kill it. But sometimes when it's a new virus or certain form of virus where the body is not accustomed to, they launch an aberrant immune response where it is not totally appropriate with the amount of immune response required to kill that virus, and it can be much, much more. And this attack can damage other organs of our body as well, other than the virus itself. This cytokine storm is nothing new. This has been, this cytokine storm is prevalent with dengue virus as well. One of the causes of the problems that we have with dengue virus is this cytokine storm. So why? Because the body doesn't know how to fight back the dengue properly. It's true also with this COVID infection. So there's an enormous amount of cytokine available, immunologically active agents available, which goes and attacks the viruses as well as the different parts of the body. So when this attack is launched, this period is called the cytokine storm. It's like a tsunami, a huge amount of immunologically active particles available. So this is apparent by two things. Number one, the patient would start having a drop in his oxygen saturation level rapidly, suddenly. And this is the first sign. And the patient might not feel that the oxygen level is going down. So what you have to do is you repeatedly check the oxygen saturation. If you suddenly see that the oxygen saturation is going down, you understand that imminent cytokine storm is ahead. Number two, some patients might develop a fever during this period. The fever was gone and suddenly they have this fever back again. This is an immunological fever rather than the viral fever that they had before. It's a response to the immunological reaction. And other than that, we can do certain tests. The best thing to do is to look at the IL-6 level, but IL-1 level, but that's not available in our country. So what we can do is we can check the C-reactive protein level. Sudden rise in the C-reactive protein level indicates that the cytokine storm is there. And this is where, if we can hit it properly, we can directly stop the cytokine storm just then and there. And that's what I was talking about, that using tocilizumab at this stage, at exactly this point, if you can pinpoint it, it works. If you can put them on steroid exactly at this point, it works. So managing COVID is all about timing. You have to know when to attack with what. Using tocilizumab earlier or using steroid earlier will cause more harm than help, because you will be stopping the whole immune system. You don't want that. It's a calculated game. It's just like chess. You need to know exactly when to give what move. And that's how it's saved. So cytokine storm is basically an aberrant immune response, an out-of-hand immune response of our body towards the virus. Thank you.
Thank you so much. And all the fibrosis that goes on within the lung is part of the response. I think Abrar will call Sania.
Yes.
It's a long-term part of this.
Okay. So thank you, Dr. K. Mayas again. And
Thank you.
now I'd like to ask Dr. Sania Hassan. So as a senior consultant of radiation, Department of Viremia Hospital, what I'd like to know from you is that a very important diagnostic tool in case of COVID-19 patient, or rather a serious case of COVID-19 patient, is HRCT of chest. So what exactly have been your experience regarding the diagnosis through HRCT of chest? What were the common findings, and how have you dealt with them, and how have you followed those patients up during this period? Ma'am.
So good evening, everyone. Thank you for having me in this Pulsession on World Hospice and Palliative Care Day. And with esteemed panelists, some of them are my colleagues. So before going into the radiological things, I want to sort of draw from Dr. Arias and Dr. Ayaz's experience and say that this has been a challenge like no other. First few months, we are in a fear, and our patients were few, and no one was going to the hospital. So that then we were primarily dealing with COVID patients or presumed COVID patients. We didn't have means to test them. And after that, now that everything is open, there's another challenge, because you have all the patients who have waited for their health care. People have nowhere else to go. They're all coming to the hospital. And if you look at our patient bank, the who are coming, not only young patients, mostly old patients, like patients in their 60s and 70s, cancer patients, patients with long-term, like kidney patients. So we have to deal with all of these patients together right now. So it has been tremendous pressure on our healthcare system of the last 6 months. But I think I am very optimistic, because if you see where we were in March till where we are now in September, we have better understanding of the disease right now, and we have better understanding of the COVID drugs that can be used. It has evolved. Having said that, we are realizing that this is not like a respiratory illness. People have compared it to flu, but it is not something so simple. It's a very multifaceted disease. Some people, because vessels are involved, so there will be respiratory symptoms for some. Young people will have cardiac symptoms. There will be long-term neurological symptoms. So, lot of things under the COVID banner. So, as we are learning to live with COVID, we are seeing that as time passes, the disease, we will need to take long-term follow-up and care for at least most of the patients will be okay, but at least there will be some patients who will need long-term care. And that is where the challenge comes in, because it is going to overburden our already fragile healthcare system. It's going to add, say, if so much, even 1% of 1 lakh, if added, or 2% added to our follow-up and everything, it's going to overburden us. And to exclude other patients, the norm, exclude COVID and then follow-up, we are really, really overburdened. And then to separate these patients, to do them, it's like a challenge that we're facing right now. So let's, as Dr. Ayaz has said, that how, even though every day people ask me, when will this end? This is like a common question. People ask me. So I think COVID is going to be here till effective vaccine comes. And when the vaccine will be available to everybody, I think I'm estimating somewhere early 2022 for everybody. So it's in a long haul. And first thing, I think it is. I think 2022 for everybody. But of course, people who are will get the vaccine, who are in the healthcare world, will get it for us. But in our search for a vaccine, we want to get a very safe vaccine, because vaccine is not without its side effects. So I mean, I would sort of wait for a vaccine and protect myself and protect my family, rather than rush to get the first vaccine that is available, because some vaccines do have a lot of effect in the body. So let us just look at some of the COVID slides I just sort of got, so give us a better idea. So in addition to blood test, we are doing chest x-ray. And sometimes with the chest x-ray, we can only see the 50% of the lung. In a given chest x-ray, we can see only the 50% of the lung. 50% of the lung is actually hidden. And you could have a moderate disease without it being visible in the lung, because one of the things that I experienced, that the people who are having COVID, they cannot inspire properly. So their x-ray is a little bit hazy. So now you have to work out how much of it this is because he didn't take a normal x-ray with proper exposure, proper inspiration, how much of it is these infiltrations. And this is in the small cells that we call alveoli. So I think HRCT is it's a CT scan where we can take very thin slices, very high resolution, sub-millimetric, our slice thicknesses, 0.6 millimeters. So it's like less than a millimeter slice. We sample the lung to see how much of the lung is involved. And then now we can score first we can say the probability of the disease. There are findings which, if they are there, you can say this is probably COVID. And then I'm just going to move to the slide. Then we can say the severity of the disease. And on follow-up, we can say. So what we are actually looking for is all these areas which are peripheral, and a lot of people have read this, like ground glass opacities in the lung. So this is how it starts, and it can be a little for some, more for some. So we can go to the next slides, and we can see that it can evolve. Like it can be more. Should I have the next one? Yeah. So it can be a little more, but in this one is very important because I was looking at it. See, these are the vessels, and it's all around the vessel. So that actually tells you this is not a pure respiratory disease. There is a vasculitic component associated with it. So, and then you get these consolidation type, and next one, you'll see that, as Dr. Ayaz has said, when you have a cytokine storm, the lung will be white out. This is the area. So for most people, these will eventually resolve. But what we are seeing now are these areas of linear fibrosis. And this is what's concerning, because the lung is scarred because of the COVID. And this, with the scarring sometimes, next one, please. With the scarring, what happens is sometimes, next one, can you show us? Yeah. It also, the scarring causes something called a bronchitis. So the lower airways, the peripheral, they become more fibrotic, and they become permanently dilated. So what will happen to that? There is a structural damage to the lung. And once you have the structural damage, these people eventually will become more prone to more infection. They might have these areas of dilated airway. You'll have more infection. They'll be more prone to infection. Your lung volume is also decreased, because if you're looking at this, almost 50% is affected. And if it stays that way, of course, you'll be your lung capacity will decrease. So your work of breathing will increase. So all the work that you could do, as Dr. I was saying, a young man who's going to the gym, he could breathe and do everything easily. He cannot do it. And this is something that some people, at least 1% people, will have to live with. And the last one, can you, yeah. In the last one, we can see it really can actually damage the lung. And then you are with a damaged lung. And the last one, please. Yeah, so you're with this damaged lung, and then you have a lifelong of disability. You have to wait for a lung transplant at one point. So as I said, that it is not a very simple disease, though our fragile healthcare system has really coped quite well despite all the hitches in the beginning. We have it down to a systematic approach to it. We have learned a lot about it, but I think we do have a lot more to learn. And going forward, next few months will also be challenging. Winter is coming, so I don't think we are going to have a second wave. We'll have a continuous wave of COVID till we get a vaccine. So best way is to be safe and just to hold on all the things, as Dr. Ayaz is saying, that are unnecessary in life. And for the healthcare workers, it's a challenge for the healthcare workers, because when we were all students, we didn't learn how to do a fit test because these were not available. Those of us who worked abroad have experienced how to put down on a gown and how to put on safety gear. And there was such scarcity in the safety gear. On this regard, I'd like to say that there are so many different gears in the market, and to ensure the right gear for the safety workers is something the government should really clamp down on, because in a country where we don't have enough doctors, can we really afford to lose 160 doctors? I mean, this is, sorry, Arif? Can we afford to lose so much manpower? Can we afford to lose the nurses? Because they have been trained. So we are in a long haul. We will be with COVID till, I think, well into end of next year. Winter season is coming. So let us all be safe in light of the new information that surface. We should not be concerned so much with. But the contact tracing, people are like, now, I mean, I think if I go on the road and street, I see people are starting to become careless. But, we have to become more careful now, because everybody is out, right? Everybody's on the road. And this is a disease that we are going to talk about in the palliative setting also, because end of COVID will be after all we will be all countries where there's moderate to severe disease, we'll end up with a long list of patients who will need regular checkup, who will need um, regular imaging, who will need follow-up with respiratory. Some will be at home needing care till they can get a lung transplant. So just to the audience, I'd just like to say that it's not over. Many countries are like treating is at over. We are not over the first wave. We are not heading into we are still living with the COVID right now. This is the most important time to be careful because everyone's out. So your health, you have to take care of it, and your safety, you have to take care of it. This is not a simple disease, and we are the healthcare workers should brace ourselves for a long-term effects of COVID.
Thank you so much, Sania. This has been very interesting for us to see. And just one question: how many, what's the percentage of patients that this imaging that you do? What's the percentage that have the honeycomb-like effect, which is long-standing?
Well,
Lung.
I think this is the percentages. They say that this is 1%. This is the worldwide data. We do not have time to compile our data yet, but it should be about 1 to 2% have long-term fibrosis, cystic changes, which obviously they'll need long-term care for that.
Thank you so much. Both these presentations have really highlighted how important it is for us to be careful, and we really don't know what else we are going to see. Thank you. We have Dr. Das now.
You're welcome.
Okay, so thank you, Dr. Sania Hassan, again for the valuable words and for your statements regarding the condition of the HSCT chest of the patients. Next, I'd like to go to Dr. Arunakshu Das. By nature of your profession, you deal with a lot of cancer patients all the time. So what I'd like to know from you is how have you dealt with the cancer patients during this pandemic situation, because they're already in a very distressed situation, and what exactly were the challenges that you have faced? And we also know that at times cancer patients suffer severe pain on a sudden, and certain medications are required to resolve the situation. Have those things been readily available to you, or you had to take alternative measures due to the situation? Thank you.
Thank you very much. Thank you, organizer. Thank you, Rumana Appa and Pulse, for organizing such a wonderful program on this very important event of World Hospice and Palliative Care Day. Cancer is already a challenge to us, and added to COVID has become a very difficult situation, I would say. So first I'll focus on our treatment, how we addressed our challenges. Back in April and May, it was a really challenging situation to proceed with the chemotherapy, radiotherapy, and all the procedures related to cancer treatment. It was a huge challenge because our hospital have to have a very strict triage, because we cannot let in all patients and give them chemotherapy. So triaging was a very difficult part. We did not have much of COVID test at that time, March, April. So a big challenge. Fortunately, we overcome that, and now the hospital is very readily doing the COVID test. So it was really a very difficult time. And the other difficult thing is, at the beginning of the COVID, it was being heard that, and all the literatures were suggesting that cancer will be a very difficult situation in COVID because of immune suppression. A lot of patients will be affected by COVID, and because of their immune suppression, they might not do very well. So their rate of infection and their mortality and morbidity will be huge. It was a projection. With that projection, we had to prioritize our patient into 3 groups: priority 1, priority 2, and priority 3. Priority 1 is the person who will definitely need cancer treatment. 2 and 3 we can consider. So this giving chemo to this priority 1 group of patients who definitely need chemotherapy was really challenging. But we started. We have given them chemo and radiation both. But the most interesting finding that we got is a number of patients with given chemo or radiation therapy, did not have much morbidity with COVID. Very interesting finding. We're trying to compile that data. The percentage of affected patients of cancer with COVID is around 10 to 15%, not more than that, in our center where I work. And the most interesting thing, if I say the number, it will be 1 or 2, maybe one patient died of COVID. So it was a interesting finding. We thought that a lot of our patients will die of COVID or will be infected with COVID, will be affected and get admitted, but that did not happen. So this challenging time, the first 2-3 months, we were very fearful, but when we followed all the standard procedures, like when we are giving chemotherapy, we check them whether they are COVID positive or not. If they are negative, we give chemotherapy. If they are positive, we give them a rest for around 10 days, recheck again. If it is okay, then we go to chemotherapy. So we had a great facility which we had 2 separate buildings, so we were able to separate the patient. If somebody is COVID positive or we suspect as a COVID patient, we could keep the patient in a separate building we called yellow zone and red zone. If that patient is negative, turn out to be negative, then we can shift it to main building, which is a green zone. So this is the way we passed through the difficult time of COVID and the cancer. And if I say about the palliative care providing was also very difficult. Patients who needed morphine could not come to our hospital because of the lockdown. But you know, for a cancer patient and to control his pain, morphine is a must. And the difficult part is Bangladesh only Dhaka have most of the morphine supply. Outside Dhaka, there is no morphine supply. So patients suffering from pain due to cancer have to suffer really a lot, not due to COVID, but due to the lockdown and the transport gap in the country. So, and another thing is, most of the palliative patients who are bedridden cannot move from their home. They used to get doctors at their home. They used to get nurses at their home, do some blood test, something like that. Most of the patients do this local arrangement, which say contact somebody who is close to your house, bring that nurse, give that injection, so that this immobile patient can get a bit service. COVID made this complete thing shut down. So no doctors were going to home, no nurses were going to home. So palliative stage 4 patient has a huge thing. So if I summarize, I would say in last 5-6 months, in the curative setting also we had great difficulties and challenges, and also in the palliative setup we had very difficult times. But I think we have learned to cope with it and go through. So we have managed it, but all the panelists has already said that this is not going to go away very soon. So adaptation is very important. But adapt to what? Because we still don't know. We are still in the learning curve how the COVID is going to behave in next month, how is COVID going to behave in next year. So we are trying to adapt. We know cancer treatment cannot be stopped. That's why we are trying to continue with all precaution and following all standards of care. Thank you.
Thank you so much, Dr. Das. This was fantastic, and we got some interesting points that less patients are dying of COVID who are receiving anti-cancer drugs. That's very interesting. I thought with their immunity being compromised, we may see otherwise. Maybe they were more cautious. Maybe that could be another area. What do you think?
Have come to summarize on that point. It may be
Can you
what our hypothesis is. COVID patient deteriorates due to cytokine storm, but my patient who is already getting an immune suppressive drug, so a cancer patient's body don't have that much of immune capacity to produce a storm. So as storm is not happening, the patient is not deteriorating. This is one hypothesis that we are thinking about. And the other thing is definitely the cancer patients are safe. It is their practice because of their immune suppression. They wear masks in their regular lifestyle as well. They keep away from. We always say to all of our cancer patients, make a social distance. Not in COVID time, from before. So that might have contributed, but still, we are looking at our data. Maybe end of this year, we'll be able to say something what really happened, and also there is a potential role of radiation. The breast cancer patients who have got radiation to their breast have definitely got some bit of radiation to their lung. So we are still looking on that contribution of radiation, whether it's helping for protecting the lung against COVID. So time will say. I think we need some time to summarize on that. Thank you.
Thank you. Very interesting points. You all will agree. Something new that I have just learned from you. Even Dr. Sania shared that 1% will go into long-term need for COPD management eventually. So these are very important points that has come up. We should listen to someone who has been dealing with her parents from staying abroad. Abrar, will you introduce our Miss Shireen Rahman?
Yes, of course. Our next participant is Ms. Shayne Rahman. And as Dr. Rumana Dola has mentioned, she has flown all the way from the US to Bangladesh to take care of a ailing parent who has suffered from COVID-19. So what I'd like to know from you is being
No,
a receiver...
not suffered from COVID-19, just
Sorry.
to take care of her.
Sorry.
Yeah.
Apologies. So what I'd like to ask is, since you have been on the receiving end of healthcare services from both halves of the world, what are the things that you appreciate in the healthcare system of our country, and what exactly would you want in the system to improve compared to the developed countries?
Thank you for having me. I think I've learned so much from all of these medical professionals, and you've learned so much, and I've learned so much from listening to you. So in honor of today's day, World Hospice and Palliative Care, I would like to acknowledge Dr. Rumana first, because I could just take a couple of minutes to talk about how we got reconnected. We knew each other as teenagers when I was in Dhaka. But my father was not well. He was at United Hospital. And we had a chance meeting, actually, with Ramana. And I did not think my father would pass away that visit. Unfortunately, after about 3 weeks, he turned for the worse. And Dr. Ramana was very, very involved with the palliative care that he needed, and very kind, and acknowledged our wishes, my father's wishes, and honored all of us. And having lived in US for all this time, I was aware of the hospice care that's available there, and how the social workers and the doctors and everyone kind of works in conjunction to make it a very nice experience for everyone. But I did not know about what would be available in Bangladesh. And I was very grateful. And once again, thank you, Dr. Rahmana, for what you have done and what you continue to do, and bring so much dignity and honor to patients when they last days of their lives, and so much comfort to their families. So I think that's just incredible.
Pleasure.
And so after that, I have to say that my mother I've lost my father about 5 years ago. So since then, my mother has been declining with her short-term memory and all that. So my sister and I take turns to come every few months to take care of her here, because we are her only children, and we've both left a long time ago. So we've been doing that, but COVID had different kind of challenges for us. First of all, travel. We were not able to come and visit. So all of a sudden, my mother was totally dependent on the caregivers at home. So that was a challenge by itself. And then, as you can imagine, everybody had this knee-jerk reaction about COVID. People were leaving town, the caregivers and the home staff, they were leaving. So my mother had a few different people who took care of her. So we had no idea about her exposure, if they knew about their hygiene awareness. and things like that. So a lot of it, we were trying to work with them, distance sort of teaching, and we were learning ourselves. Like you said, all of the panelists agree that every day people are learning all over the world about this disease. It's so new, nobody really knows what to expect, how to handle it, what to do. So obviously we were very panic stricken from being so far away. And the challenge is, just as a layperson, we were obviously panicking more because we did not know how or what kind of resources would be available for her, as simple as going to the hospital. Dr. Arif mentioned how some hospitals were not even admitting COVID patients or any other patients. So it was kind of difficult for us to kind of, think and imagine what would happen if she did get diagnosed with COVID and she needed help, and she's 85 plus, obviously the most vulnerable age group. So, it took us several months to come here, and also we had to make some personal sacrifices with our careers and all that, just because we want to be available to give her the care that she needs and deserves. So it's been a
Let me add that Shireen was working with NASA for last 20 years, very highly qualified electrical engineer, and she actually gave up her job to come and look after her mother. After that, she was doing something else. But these are sacrifices she made.
Well, one of the reasons, honestly, thank you, Ramana, for that. I actually feel pretty inadequate amongst all these honorable panelists. But one of the things is that we had travel restrictions. If you think about the realistic problems and the restrictions that companies have, because over there, they want to make sure that their employees are all safe. And it's an HR nightmare if you think about it. They don't want you to travel. They don't want you to get sick or bring it up, or if something happens to you while you are away. So those are very difficult. And then at the same time, once you're here, you can't just say, well, I'm going to go just for 2 weeks, because you have to quarantine when you come here, and then something happens to you, then you are going to be held back. With so much unknown, it's just a lot of anxiety and mental health issue for people as well. So just being on the other side of it, and not knowing and not being aware of what's available here versus what you want to do, it's also difficult. So I think all this discussion and the learning and the communication is so important. Because I think as we learn more about COVID, as we learn about the resources that's available here, those of us who have to manage our parents' care from another country, it's just so much easier for us to do and to be connected. So thank you so much for doing what you do every day, for taking care of the patients, and for reaching out and teaching everyone. So it's really important, and I'm just honored to be part of this. Thank you so much.
Thank you, Shireen, for sharing your experience with us. And hopefully we can do some more work so that, if someone like you who's working abroad can relax when we can take care of your parents much better. And hope organizations and government will come forward to enable each of us who are trained a little bit, so that we can make something available for you all.
And that's the key, because the unknown, who to call, how to make the arrangement. Can you have somebody come and take care of her at home, or is it better for her to be at the hospital than to which hospital to go to, or depending on their other health issues perhaps. So I think it's just it just opened up a lot of other things that we may not have been thinking about.
Right. Thank you. We'll have another session on this altogether, including the legality. We'll include our family eventually to help us know what else we can do legally, which is possible for home care. Thank you, Shireen.
Thank you very much.
Thank you.
Okay. So thank you, Ms. Shayne Rahman. Next, I'd like to go to Dr. Ishrat Jahan. Hope you're having a nice day. And my question towards you is what are the different innovative ways to deal with the COVID-19 situation, in your opinion? And what are the challenges that you have faced in your particular field, and how have you come up with a relative solution to that?
Okay, thank you very much, to Dr. Abrar.
No problem. This is part of our, family.
That's fine.
She can watch with you. We are very inclusive.
Okay, she was quiet, but just now she started crying because it took a long time. So, from my part, when I have started with working with the Bangladesh Palliative and Supportive Care Foundation, it's I'm so sorry that she came here. So here, when I have started working, so there, we at first, before COVID, we have started. We have done a lot of home care patients. We have dealt a lot of home care patients. But when the COVID-19 started, then the challenges we have faced most, that was the manpower issue and the trust issue from both sides, because the patient thinks whether my employee or our nurses are carrying the COVID-19 virus, or the nurses thought that the patient or patient's attendant might have the coronavirus. So that was the issue. But we have dealt that very nicely, that when we sent our any nurse or any caregiver to any patient's home, then we have ensured that they have the COVID-19 negative virus. COVID virus negative.
Uh, Ishrat, you can take care of her a few minutes. We will handle few questions in the meantime. I think, Abra, let's go to the question, then Ishrat can share later. Do you have questions for any of our
Yes,
panelists now?
we have a series of questions being lined up. So, firstly, I can go to Dr. Ayaz again for one question. Dr. Ayaz has mentioned the use of steroids in the treatment of COVID-19 among the various options. So, one of the audience wants to know, what exactly is the role of steroid in this case? What does it do for a patient suffering from COVID-19?
Uh, Dr. Ayaz, can you take that question now? He said he'll be listening and he'll be back. Any other question for other
Okay, let's try.
panelists? Yeah, he's here. He's here. Please. Yeah. Ji. Dr. Ayaz, please.
Can I just take a minute's time, please? I'm online with another patient. Just I'll
Okay,
be back in
okay.
a minute. Can you take another?
No problem.
Okay, 1 minute. Yeah. Okay.
Okay, in the
So,
meantime, I
have
want
a-
to finish my topic. That is, while we were started visiting our patient, then we have ensured from both sides that both of them are not COVID positive. And another thing, when any patient contacted us, we have started there. At first, we have communicated with the telemedicine, and through the telemedicine, we have took care of the patient and counseled them. And if there is any dilemma, that decision making or any sort of other pain medicine or any sort of decision making, then we have counseled them and helped them through telemedicine. And while there is a nursing issue, then we have ensured our trained nurse to them. In the meantime, from the BPSCF, we have visited in 2020, we have visited already 370 patients in hospital or hospital and home together. And home visit patient number of home visit patient was 28. 28 patients took home care from the January to until now. And now we have 5 patients at the same time. We are providing home care and telemedicine and other things. And though we have faced a lot of challenges, because of when the lockdown has been started, most of the trained nurses and caregiver went back to their hometown. And that was the issue. We couldn't provide the trained nurses and caregiver. But after the lockdown finishes, then we just turned them back and ensured our home visit. And when the patient needs anything, any support like IV infusion or IV saline or anything, then our nurses just visit their home, and we conduct from the doctor also visited there, and the whole part is conducted by telemedicine and through internet, and we keep record of our each and every patients, so that when the patient comes after long time, then we can follow up them properly. That's the issue. Okay.
Thank you so much. We'll listen about Sweden later. We can go back to questions since Dr. Ayaz he's back.
Yes. So
I'm back. I'm sorry. I was seeing patients in between. I'm very sorry.
We like that because you're busy.
So the question that one of the audience that have for you is, what exactly is the role of steroid that you have mentioned in case of a COVID-19 patient?
Okay, so as we have discussed before, that COVID is absolutely a disease of an immunological reaction, just like Dr. Sania has mentioned, that it is basically a vasculitis. It's basically inflammation of the lungs. It's basically inflammation of the heart, myocarditis. So steroid is an anti-inflammatory agent. The basic mechanism through which steroids act here is, number one, it acts as an anti-inflammatory agent, which decreases the inflammation, and it acts as an agent which decreases the immune response. As we have mentioned, that we have an overwhelming immune response during COVID. So steroid cuts down on that immune response, as well as it's rather, we can say that it puts a cap on it so that it doesn't affect too much, and it also decreases the inflammation. As a result, we get a balanced output, and the whole process is properly stopped and treated. So basically, steroid acts as an anti-inflammatory agent and an immunosuppressive agent in this
Thank
case.
you. I have a question. So dexamethasone and methylprednisolone. Why are we giving methylprednisolone when it is let's say when someone is desaturating and in hospital, and not dexa? Would you kindly share?
There are a number of studies. The study that we based on orodaxone or dexamethasone is basically the study that was undertaken in the UK. So they had this study which showed that they have got very good response in patients who are in ICU setting with 6 milligrams of dexamethasone tablet.
Yes.
Other than that, yes, dexamethasone tablet. But other than that, there are a number of other studies in the US, in the UK, and other parts of the world, which has shown methylprednisolone to have even a better effect than dexamethasone in these cases. The basic thing that we look into is every steroid has got more or less the same action, but some steroid has got more water and mineralocorticoid activities than the others. So water logging is something we don't want. Methylprednisolone and dexamethasone has got a less amount of water logging activity. That's why it's preferred compared to the other steroids. And technically, if you look at it, we can say that yes, maybe both of them are working in almost the same manner. But methylprednisolone has shown to be more effective as an anti-fibrotic agent. Even we have used methylprednisolone previously as an anti-immunological agent for treating rheumatoid arthritis with severe pain or inflammation. We have used it for ankylosing spondylitis. So we know that methylprednisolone acts as an anti-inflammatory agent and an immunosuppressive agent and an anti-fibrotic agent as well. That's why we prefer methylprednisolone over dexamethasone in treating a cytokine storm or a patient is just desaturating very fast, because we believe that the action is much more better. Not only does it have this anti-inflammatory effect, it has also got a very good anti-cytokine effect as well. That's the reason. Over dexamethasone. The dexamethasone has been more hyped due to the UK study. That's it, basically.
Exactly. I thought so. I just wanted everyone to hear this. Thank you so much. Thank you.
Okay, so the next question is for Dr. Sania Ahsan. I'd like to ask two questions at the same time, and please give us a brief explanation to both. Is there any possible changes in neurological parameters as far as radiological aspect is concerned in a patient infected with COVID-19? And secondly, as far as lung damage is concerned, how much of that lung damage is permanent for a patient?
Well, first I'll talk about the lung damage. So we've seen that with prolonged treatment, some of the consolidation will actually resolve. So 50 to 60%. What we are seeing that the bands that are left back, they don't normally resolve or they stay back. So my recommendation is these are atelectatic bands, meaning what we call areas of lung which is not inflated. So I highly recommend that post-COVID there should be some respiratory exercise. You have to continue that. But once you have the bronchiectasis, cystic changes, then it's pretty permanent. Then you cannot that is a permanent change in the lung. Now, neurological patients, we've had a few. Most of them have been elderly. So we don't have any specific opacity in the brain that we can attribute to COVID itself. So this has become very challenging because there is no sort of acute changes in the brain. But having said that, I want to ask Dr. Az that, remember, it's a vasculitic disease. So if it's a medium to small vessel vasculitis, there can be ongoing inflammation in the brain, and it will take time for it to be visible. So that can only be seen, I think, small vessel vasculitis. If it affects the brain, you can only see it to dural biopsy. And honestly, we have not had many features in radiology attributed to COVID alone, pathognomic of COVID in the brain. So, but just because it's not been mentioned, it doesn't mean it's not there, because we have to, and we've not had a lot of time with it also, no? So we have to see probably few young patients with COVID and neurological symptoms and follow them up. And then in follow-up, we have to see they've lost brain volume to conclude that there is ongoing vasculitis. So I think that could be an approach.
Dr. Ayaz, would you like to add to that? Thank you, Sania. That was excellent. Neurological effects.
Yes, just like as Dr. Sania has said, I do believe that it's a vasculitic event that goes on, maybe. And the other thing is that the hypothesis is that the COVID virus acts through the ACE2 receptor, and there are 5 organs that have definitive ACE2 receptors in them, and brain is one of them. So definitively an attachment of the virus on the ACE2 receptor in the brain might be one of the reasons why COVID is affecting in this manner. So the 5 organs other than the brain that has got these ACE2 receptors are basically the lungs, the heart, the intestinal system, the kidneys that we have, and the brain. So these are the 5 organs that are being affected currently with COVID. And probably these are all the reasons why we have this immunological reaction of COVID in this organ. So they basically bind with the ACE2 receptors, then they push on a cascade of reactions. This cascade of reactions pull in the immunologically active cytokines like the IL-6 and the others. And this, on the other hand, turns on the vasculitic phenomena in the brain, or it makes the brain permeability more, and more toxic agent can get into the brain, causing all the harms that we see currently. That might be one of the reasons. Thank you.
Thank you so much. Excellent explanations from both of you. Thank you.
Thank you. I have some other questions, but those are mainly related to palliative care. And I guess I'd be more comfortable asking those after Dr. Rumana Dola has finished her section of the discussion. What I'd like to ask right now is one of the questions that have been coming for twice or thrice now. What exactly is the difference between hospice and palliative care?
Okay. So palliative care is an approach that takes care of a patient from holistic in a holistic way, and that means we take care of patients looking at their physical, mental, social, psychological, and spiritual issues, not just looking at their physical issues, which is normally what we do in medicine. So, this holistic approach helps to take care of our patients and relieve them of their suffering. We also take into account patients' families when we take care of the patient. So, that is one way of providing palliative care. Palliative care should ideally start from the beginning of a long term disease. Say, if a patient has had cancer, and patient, let's say, will be cured, will be very happy if they're cured. Sometimes it may come back, or there may be another complication. So if the palliative care physician is introduced to the patients from the beginning of the treatment, then the care is holistic. See, a patient, when taking treatment, eventually may have pain issues, may have other issues. So the palliative physician can come in and take care of that, which we do in our hospital at United Cancer Care Center. Our physicians also refer patients when they suffer from pain or other issues or goal setting. So it's a teamwork. Palliative care starts from early days and can continue even after death, up to bereavement care. So that is one. And when we say hospice care, generally we mean last 6 months. There are few countries in the world where when few physicians think decide that this patient has less than 6 months to live, where we have some prognostic criteria and other criteria to come to that sort of decision. So a number of physicians, at least 2 to 3 physicians, would decide that yes, this person does not seem to have more than 6 months with for himself or herself. Then they're referred to hospice care. And that means no aggressive treatment, no unnecessary intervention, and the patient, of course, has the option to decide. So that is the hospice care, which we understand very simply, and in short, that is what it means. And up to
Thank
end
you,
of
ma'am.
life care. Yes, thank you.
Yes.
And bereavement
Okay.
care as well.
So I think a large part of the difference between the two words lies in between the estimated remaining lifespan of the patient as we speak about this.
It's one can be from the beginning, and hospice care is usually it means last 6 months, but sometimes people interchange palliative care and hospice care, thinking it's the same thing.
Right. Okay. Thank you. So I'd actually like to get back to you because you are the last member of the panel to continue the discussion. What I'd like to know from you is what are your thoughts regarding long-term care of the COVID-19 patients? We have plenty of elderly patients who have suffered from the disease and recovered initially, but are having some sort of complications, multiple ones later on. So what is or should be a standard approach towards those patients, and can holistic approach, as you have mentioned, be an answer to this condition?
Thank you so much for your question. See, not just post-COVID patients. I'm talking about generally, this pandemic has all sorts of effect on people, and we need to have special care in place. We really have to think about alternatives than just going to hospital and only seeing physicians. We have to enable home care. We have to enable virtual healthcare like Pulse, like other telemedicine services. We have to take care of patients and their families for their physical, mental, social, and spiritual well-being, as I've mentioned few times already. And when we do that, we have to think of all the patients who have chronic diseases, sometimes or acute problem. They cannot be at the hospital. Then what do they do? So it's overall health system which is already looking at this issue and handling it as we face the problem. But we really need to have a long-term, uh, long-term sort of organized way of dealing with this, so that like a triage, like a mild, moderate, severe need of care, and then we deal with it. And hospitals also are now aware of this, as Dr. Arif has mentioned, that triage is important, and patients who can take their treatment from home can consult through telemedicine and stay at home and take the treatment. So we have to think of this from a different way. We need not think from hospital. We need to think from patient's end, what is comfortable for the patient. And in terms of post-COVID issues, I think we are looking at, first of all of us, even if we have not had COVID-19, we are in an abnormal situation. We're not having the normal social life that we used to have. It's having a huge mental health related problem, anxiety, fear, other symptoms which we may harbor are now precipitated, as Dr. Ayaz has already mentioned. So we have to look into that. There is also increase in violence we have to keep in mind. So when we talk about palliative medicine, we think sometimes it's about end of life, but it's about relieving suffering from anyone who's suffering. So it may be pain medication, it may be suffering due to mental health issues, it may be long-term care, it may be nursing care at home, it may be doctor's visit at home or doctor's consultation through virtual platform. All these have to come into play, and the patients who are now going to have long term effects which are neurological, or let's say will end up with COPD, long standing lung diseases, what are they going to do now? If someone needs lung transplant, say 1%, that may also be quite a few people who, so lung transplant may not be possible for everybody. So then they become someone who will benefit from palliative care approach. So there is continuous counseling, goal setting, helping them to decide on what is important. Another thing palliative care does is, we talk about dying. We help patient think about their fear of death slowly. We don't mention the word death always. We try to understand if they're afraid of the last days of life, then they can share their anxiety. And we have that conversation, and sometimes family protects patient and they don't discuss it. So we also take care so that there is no collusion, meaning family tries to protect the patient is not discussing their problem, and there is huge gap. So there are these areas. It's very long topics. I don't want to go on into much details. I want to say that all of us need to be the voices of the voiceless. We have to take care of people who are suffering. We have to take care of the elders. We say the decade of older person, is an important area that we are going to talk about in World Health Assembly. We want palliative care to be part of the universal healthcare coverage. We want it to be included in the sustainable healthcare. So all these are important areas that we need to think about. So at the end, I want to end with something funny. I don't know if Anika, do you have the slide that I have, that we are having so many webinars? We deal with end of life, but we don't want to make it a dangerous situation for everybody, that we kind of collapse with too many webinars. So I'm just sharing these pictures. I don't want our viewers to have this kind of fatigue. And I'd like to say thank you for being with us today. And we hope to bring you more programs in the future with more details. Thank you. And I thank all our friends and panelists who were with us today.
Thank you very much.
Thank you so much, Dr. Rumana Dola. And this was a very informative session, I have to say. I have got to learn a lot in the last 1.5 hours, and the same goes for all the audience, I guess, as well. So thank you so much, and wish we could meet again very soon and have a live session again. And to all the audience, I guess you have got to know a lot more about the disease. We always think we have known about the disease enough by now, but it's not the case. There are some aspects of the disease still undiscovered regarding the vaccine or the possible comorbidities attached to it or the symptoms. So much more to know, and we have to stay safe for a longer time. It's really not the time to go out and start having fun again. So I really hope all of you understand the situation and react more responsibly, and hopefully everyone stays safe. Thank you.
Thank you very much.
Thank you very much.
Thank you very much.